If you're over 65 or you care about someone who is, there is something almost nobody talks about clearly enough during a heat wave. Two people can walk into the exact same hot afternoon, sit on the exact same porch, drink a similar amount of water, and one of them starts getting dizzy, weak, confused, flushed, maybe even dangerously overheated much faster than the other. And sometimes the difference is not just age. Sometimes the difference is what's sitting in the pill organizer on the kitchen counter. Now, I want to be honest with you right from the start. This is not going to be one of those videos where someone just says, stay hydrated, stay in the shade, wear light clothing, and then acts like the mystery is solved. Those things matter. They absolutely matter. But the actual biology of why some medications make heat so much more dangerous, especially in seniors, is far more interesting than a generic summer safety checklist. And I also want to be clear about something else right away. This is not a stop your medicine video. Some of the medications we're going to talk about are essential. Some people genuinely need them for blood pressure, heart disease, Parkinson's, depression, sleep, bladder symptoms, or other serious conditions. The point here is not panic. The point is understanding. Because once you understand how heat stroke happens, and once you understand how certain medications quietly remove pieces of your body's cooling system, the danger starts to make sense in a way that is very hard to forget. That is the kind of knowledge that actually changes behavior, not fear, not headlines, understanding. So what I want to do today is walk you through the hidden mechanics of heat protection in the body. Why older adults are more vulnerable to heat even before medication enters the picture, and then the 9 common medication categories that can raise the risk of heat exhaustion and heat stroke in seniors. And by the time we get to the end, you're not just going to have a list. You're going to understand the pattern behind the list. And once you see the pattern, you'll start noticing risk where most people never think to look. Let's build it from the ground up. The first thing to understand is that heat stroke is not just feeling too hot. Heat stroke is a medical emergency. It happens when the body's temperature control system starts to fail and core temperature rises into dangerous territory. This is the moment when cooling is no longer keeping up with heat gain. And when that tipping point is crossed, the brain, the heart, the kidneys, and other organs can start getting into trouble very quickly. Before heat stroke comes heat exhaustion. That is often the warning phase. Heavy sweating, weakness, nausea, headache, dizziness, rapid pulse, feeling clammy, feeling like you might faint. That stage matters because it is your body telling you, I am losing control of this situation. Heat stroke is what comes next when the body can't recover. Confusion, strange behavior, fainting, very hot skin, sometimes dry skin, sometimes not, a strong, rapid pulse, or in some cases, a weak one. This is not discomfort anymore. This is an emergency. Now here's the part that matters for the rest of this video. Your body has several ways to prevent that emergency from happening. It sweats. Sweat evaporates off the skin and carries heat away. It widens blood vessels near the skin, so warm blood can release heat to the outside world. It keeps blood pressure stable enough to move that blood where it needs to go. It triggers thirst, so you replace fluid losses. It keeps your brain alert enough to notice overheating and do something about it. It keeps your kidneys and electrolytes balanced well enough for that whole system to keep running. That is your built-in heat defense network: sweating, blood flow, thirst, circulation, alertness, fluid balance. And medications can interfere with almost every one of those. Some reduce sweating, some reduce thirst, some make you lose water faster, some lower blood pressure so much that hot weather becomes harder to tolerate, some reduce blood flow to the skin, some affect the brain's ability to regulate temperature, some cause sedation, which means a person doesn't respond quickly when their body starts sending out danger signals. And the really important thing is that these effects can stack. That stacking effect is one of the biggest reasons seniors are at higher risk, because aging itself already changes heat tolerance. Older adults usually do not adjust as well to sudden temperature changes. Thirst cues can become less reliable. Sweating response may be blunted. Skin blood flow can be less efficient. Chronic medical conditions are more common. kidney function may be less forgiving. And many seniors are taking more than one medication at the same time, not one heat-sensitive medication, two, three, four, sometimes more. So the real question is not which single pill causes heat stroke all by itself. The real question is which medications quietly take away one or more of your cooling tools until a hot day becomes much more dangerous than it looks. That is the right question. So let's go through the 9 categories. The first group is diuretics, often called water pills. These are incredibly common in older adults. They're prescribed for high blood pressure, heart failure, swelling, and other conditions. Examples include furosemide, hydrochlorothiazide, and chlorthalidone. And on paper, the basic function of a diuretic sounds simple. It tells the body to get rid of more salt and water through urine. Now, under normal conditions, that may be part of the treatment goal, but in extreme heat, that same effect can become a problem because the body is already losing water through sweating. So you have sweating pulling fluid out one way and a diuretic pulling fluid out another. And once dehydration starts building, blood volume drops, blood pressure may fall, electrolytes can get out of balance, and the heart has a harder time supporting circulation under heat stress. This is why an older adult on a water pill can get into trouble faster than expected. They may not look like they're doing anything dramatic. They may just be sitting outside, doing light yard work, walking to the mailbox, or spending a few hours in a house that's warmer than they realize. But the fluid reserve is already smaller. The margin for error is already thinner, and that brings us directly to the second group, ACE inhibitors and ARBs. These are also extremely common. Medications like lisinopril, enalapril, losartan, and valsartan are used for blood pressure, heart disease, kidney protection, and more. These drugs do not all work the same way as diuretics, but they can still complicate heat tolerance. They may contribute to low blood pressure under heat stress, and public health guidance has also flagged reduced thirst sensation and fluid balance issues as part of the concern. Now, on their own, some people tolerate these medications just fine in hot weather. But when you combine them with age, high temperatures, possible dehydration, and sometimes a diuretic on top, that's when the picture changes. This is the pattern I want you to notice. Heat risk is not always about one dramatic medication. It is often about multiple small disadvantages happening at the same time. The third group is beta blockers. This one is particularly important because it sounds like a heart issue, but it becomes a cooling issue. Beta blockers like metoprolol, atenolol, propranolol, and carvedilol are prescribed for blood pressure, heart rhythm problems, angina, and heart protection. The problem in heat is that some beta blockers can reduce blood flow to the skin and blunt the body's ability to move heat outward. That matters because one of the main ways the body cools itself is by sending warm blood toward the skin so heat can dissipate. If that pathway is weakened, it becomes harder to unload heat. And in older adults, even a subtle reduction in that cooling efficiency can matter. There's another layer here too. Beta blockers can also make it harder for a person to recognize effort and heat stress the way they normally would. The heart rate response may be blunted, so the body can be struggling more than the person realizes. That mismatch matters because sometimes people do not stop activity when they should stop activity simply because the warning signals don't feel as obvious. The fourth group is anticholinergic medications. Now, this is where the story gets really important because anticholinergic effects show up in more medications than many people realize. These drugs block certain nerve signals, and that can help with different symptoms depending on the medication. Some are used for bladder urgency, some for dizziness, some for nausea, some for muscle spasms. Some even show up in older sleep aids and cold medicines. Here's why they matter so much in heat. Strong anticholinergic medications can reduce sweating. And if sweating is one of the body's main cooling tools, that is a serious problem. If you can't sweat well, you cannot evaporate heat off the skin efficiently. The internal temperature can climb faster than it should. This is one of the clearest mechanisms in the entire conversation, and it's one reason clinicians pay close attention to anticholinergic burden in older adults. Not just because of heat, by the way, but because anticholinergic drugs can also affect memory, confusion, dry mouth, constipation, and overall vulnerability in seniors. But in hot weather, the sweating issue becomes center stage. And now we get to a group that overlaps with that category, but deserves its own spotlight because so many people take it casually without thinking of it as heat related medicine at all. Sedating antihistamines. Medications like diphenhydramine, doxylamine, and promethazine are a big deal here. People think of them as allergy medicines, nighttime cold medicines, motion sickness medicines, or sleep aids. They don't think of them as heat risk medications, but many of them have anticholinergic properties, which means they can impair sweating. And some of them are sedating, which adds a second layer of risk. This combination is more serious than it looks. Reduced sweating means reduced cooling. Sedation means slower recognition of danger. So imagine an older adult in a warm bedroom, maybe without ideal air conditioning, after taking a sedating nighttime medication. The room gets hotter than expected. They become more dehydrated overnight. They may not wake up as quickly, may not notice the heat clearly, may not respond quickly, and may already be carrying that anticholinergic reduction in sweating. That is exactly the kind of quiet scenario where risk grows without looking dramatic at first. The sixth group is antidepressants. Now, this is not one single uniform category. Different antidepressants behave differently. Some may increase sweating, some may decrease it, some may affect thirst, some may influence central temperature regulation. Tricyclic antidepressants, in particular, can carry stronger anticholinergic effects, which brings us right back to the sweating issue again. Other antidepressants, including SSRIs and SNRIs, are also on public health watch lists for heat-related sensitivity, though the mechanism may vary. The most important point here is not that every antidepressant creates the same level of risk. It's that mood medications are part of this conversation, especially in older adults, especially during extreme heat, and especially when other heat-sensitive medications are already in the mix. And there's another subtle piece of this. Some people taking antidepressants may also experience fatigue, lightheadedness, appetite changes, or altered sleep. None of that automatically means danger. But in hot weather, those signals can blur together. A person may think, I'm just tired today. I'm just a little off. I just didn't sleep well. And what is actually happening is that heat stress is building underneath symptoms they are already used to brushing aside. The seventh group is antipsychotic medications. These are among the most important drugs to flag in a heat discussion because they can interfere with central thermoregulation, the brain-level control of body temperature. Some can also impair sweating, cause sedation, or reduce awareness of overheating, and that combination can be extremely dangerous. This is not a new concern, by the way. Heat vulnerability with antipsychotics has been discussed for years because the mechanism makes sense and the clinical concern is real. If a medication affects how the brain regulates temperature and at the same time affects alertness or sweating, then a hot environment becomes much harder to manage safely. And with seniors, the stakes are even higher. Because cognition may already be more fragile, mobility may already be limited. A person may not get up quickly, may not seek a cooler environment quickly, or may not describe symptoms clearly in time. That delay is exactly what turns a manageable heat problem into an emergency. The eighth group is sedatives, tranquilizers, and other medications that can dull alertness. This includes drugs like benzodiazepines, some sleep medications, and in some situations, opioid pain medicines or other central nervous system depressants. Now, these medicines do not all raise heat the same way. Some of the risk here is less about sweating and more about behavior, awareness, and response time. And that may sound less dramatic, but it is not less important. Because the body's heat protection system is not purely automatic. It also depends on decision making. You have to notice you're overheating. You have to get out of the sun. You have to drink something. You have to recognize that the dizziness is not normal. You have to respond to the warning signs before they become severe. Sedating medications can slow all of that down. They can also increase fall risk if someone becomes dizzy or hypotensive in the heat. So now the problem is no longer just overheating. It's overheating plus confusion, plus slower reaction time, plus maybe a fall, plus maybe living alone. That is how seemingly ordinary situations become medical emergencies. And the ninth group is Parkinson's medications and related treatments. This category does not get talked about enough. Parkinson's disease itself can already complicate autonomic function, movement, sweating patterns, and overall resilience in hot weather. Then add medications used in Parkinson's treatment, and the picture can become even more complex. Recent evidence has pointed to anti-Parkinson agents as one of the medication groups with measurable effects on thermoregulation under heat stress. Now, I want to be precise here. That does not mean everyone on Parkinson's medication is headed toward heat stroke. Not at all. It means this is a group that deserves special awareness. Because many people with Parkinson's are older adults, may have mobility limitations, may already be more vulnerable to dehydration or blood pressure shifts, and may take multiple medications at once. Once again, the theme is stacking. And if you've been paying attention, you may have noticed something about this list. These 9 categories do not all do the same thing. That is exactly the point. Diuretics pull away fluid. ACE inhibitors and ARBs can complicate thirst, fluid balance, and blood pressure under heat stress. Beta blockers can reduce heat dissipation through the skin. Anticholinergics and some antihistamines can reduce sweating. Antidepressants and antipsychotics can interfere with central temperature control, thirst, or sweating depending on the drug. Sedatives can reduce awareness and delay response. Parkinson's medications add another layer to already vulnerable temperature regulation. Different doorways, same destination, a body that handles heat less effectively. And this is why older adults on multiple medications need a different level of respect for hot weather than younger people often do. Not because they are weak, not because they are fragile in some abstract sense, but because the physiology is different and the medication burden is different. Now, I want to spend a moment on something that is incredibly important and often missed. Heat risk is not just about being outside in blazing sun. A lot of heat-related emergencies happen indoors: a warm bedroom at night, a house without adequate air conditioning, a power outage, a person living alone who doesn't realize how hot the room has become, a senior who says, "I'm fine, I'm just tired," and goes back to the recliner while the body keeps getting hotter and drier. That scenario matters because people often imagine heat stroke as a dramatic outdoor collapse. But the path to heat stroke is often quieter than that. It can look like weakness, confusion, nausea, headache, restlessness, a change in behavior that seems subtle until suddenly it isn't. So what are the warning signs that should make people pay attention sooner? Heat exhaustion often looks like heavy sweating, weakness, dizziness, nausea, headache, fast pulse, muscle cramps, feeling clammy or feeling faint. Heat stroke looks more severe: confusion, acting strangely, fainting, very hot skin, sometimes not sweating even though it's hot, a strong, rapid pulse, or sometimes a weak one. At that point, this is emergency territory. And I want to say this plainly because it matters. Confusion during extreme heat in an older adult should never be brushed off casually. Not as just being tired, not as just getting older, not as maybe they skipped lunch. Heat can affect the brain quickly, and confusion is one of the most important red flags in the whole picture. Now, there's another layer here that makes this topic even more interesting and honestly more concerning. The danger is often not one medication, it is combinations. A senior may be taking a diuretic for blood pressure, a beta blocker for the heart, an antidepressant, and an over-the-counter sleep aid with anticholinergic effects. None of those choices sounds shocking in isolation. In fact, it may describe an extremely ordinary medicine cabinet, but look at what that combination can do in hot weather. Less fluid reserve, less heat dissipation, less sweating, less alertness, less room for error. That is the real story, and it is one reason public health guidance keeps emphasizing medication review ahead of hot weather, not during a crisis after symptoms start. Now, because this is an educational video and not a medication instruction plan, I want to be very careful here. The correct response to learning this is not to stop medications on your own. Some medicines can be dangerous to stop abruptly. The real takeaway is awareness and preparation. Which medications on the list apply to you or to someone you care about? Are there multiple heat-sensitive drugs being used at the same time? Does the person live alone? Do they have air conditioning? Do they have someone who checks on them during extreme heat? Do they know the early signs of heat exhaustion? Have they ever been told whether their fluid intake has to be limited for medical reasons? That is the level of conversation this topic deserves. Because once the heat wave arrives, you do not want to be figuring this out from scratch. And I think this is where a lot of people get misled. They assume heat safety is mainly about willpower. Drink more water, tough it out, stay inside for a while, turn on a fan. But fans are not enough in serious heat for many older adults, especially if the indoor temperature keeps climbing. And hydration, while important, is not a magic shield if sweating is impaired, blood pressure is unstable, and the brain's response to heat is altered. This is a systems problem. That is the phrase I want you to remember. A systems problem. Heat stroke is what happens when enough parts of the system stop compensating. And medications matter because they quietly remove those compensations one by one. Before I close, I want to tell you the practical framework I think viewers should keep in mind, not as medical advice, but as a way to organize the risk. First, know the medication categories. If you or a loved one is over 65 and takes diuretics, heart medicines like beta blockers or ACE inhibitors or ARBs, strong anticholinergics, sedating antihistamines, antidepressants, antipsychotics, sedatives, or Parkinson's medications, that person deserves more caution in hot weather, not less. Second, respect combinations more than single drugs. One medication may increase risk modestly. Several together can change the whole picture. Third, watch the behavior, not just the thermometer. A senior saying, "I feel weak, I feel strange, I feel dizzy, I'm not thinking clearly, I'm nauseated, I have a pounding headache," that matters. Those are not symptoms to sleep off in extreme heat. Fourth, do not assume being indoors means being safe. Hot homes are dangerous. Warm nights are dangerous. Power outages are dangerous. Poor ventilation is dangerous. And fifth, never turn this into a self-medication experiment. This is where a clinician or pharmacist matters. Medication plans, fluid guidance, and hot weather precautions are conversations to have before trouble starts, not after someone is already confused and overheating. Let me close with this. Every summer, millions of people hear general heat advice, and some of it is good advice. But the real danger for a lot of seniors is not just the weather report. It's the intersection between the weather report and the medicine list. That's the part that stays invisible until it suddenly isn't invisible anymore. And once you understand that, the whole picture changes. You stop asking, "How hot is it outside?" And you start asking, what tools does this person's body still have available to cool itself? Can they sweat normally? Can they feel thirst normally? Can they keep blood pressure and circulation stable? Can they move heat to the skin effectively? Will they notice the danger in time? That is a much smarter question. Because heat stroke in older adults is very often not random. It is the end result of a system being pushed past its ability to adapt. And certain medications can move that tipping point much closer than most people realize. So the next time you hear that extreme heat is coming, don't just think about sunscreen, cold drinks, or whether the forecast says 95 or 100. Think about the much more important question hiding underneath all of that. What might the medications be doing to the body before the heat even arrives? That is where prevention starts. If this video helped you understand the topic in a way that felt clearer and more useful, make sure to subscribe to the channel. And if you want, leave a comment telling me which of these 9 medication groups surprised you most. Thanks for watching, and I'll see you in the next video.